there's lots of activity happening in the world of menopause, or really women's health, and how do we do a better job? I mean, women have just been forgotten when it comes to healthcare. And there's a lot of activity. FDA convened a panel to talk about hormone therapy, go through all the misinformation that has been put out there with the Women's Health Initiative. How do we modify our recommendations? Black box warnings that's on vaginal estrogen. What's the role of testosterone in menopause? So there's lots of, rightfully so and thankfully, there's information coming out, conversation around how do we take care of women in a better fashion. So if you haven't seen any of that, just Google FDA, women's health, testosterone. There's some women that have been convened that have been doing hormone therapy for many, many years. And they were asked to be a part of this FDA panel to start collecting some information and data and expert opinion around hormone therapy. I'm doing great. I hope you're doing well too. It's a beautiful day in Portland. Oh my gosh, it's amazing out there. I don't know if it's gotten hotter though. I was out there earlier. So yeah, if you haven't seen that, I would Google it. Stay informed. I will say, now granted, this may just be what gets fed, right? The social media bots and algorithms, but there was a picture, I think there's 4 or 5 women that were asked to sit on this FDA panel and give expert opinion, and there are no black women up there. At this point in my career, I don't consider myself, an expert, but I know there are other black female physicians, or maybe there are black male physicians doing hormone therapy, but I know for sure there's other female black physicians that are doing hormone therapy, and it just, in this day and age, it's sad to see that we don't have a black doc up there that's giving some expert opinion. And maybe I'm remiss, but at least what the picture that I saw. So I'm going to do some research and see if that's truly the case, because we need some representation, right? It matters. It just freaking matters. So it's just sad to see. So there's that going on in the world of menopause. What I wanted to talk about today was something called a coronary artery calcium score. And I was asked by someone, hey, should I get one? And I honestly do. So if you have questions, ask me the question, because then I'll spend some time talking about it. Things that I see a lot, that's usually what'll come up. But if someone has a specific question, then I prepare something around that. So if there's something you're wondering about, send it to me, and then I can answer that question, and then it's to the benefit of everybody else, because generally other people are thinking about it too. So I wanted to talk about, what is this test? Why do we use it? When do we use it? How is it maybe looked at differently when it comes to menopause? Should it be looked at differently when it comes to women's health, and how menopause may factor into it? And does that change how we would evaluate its use? So that's kind of my goal for today. So this is a topic that I think also is applicable for men. So for, spouses, partners, brothers, uncles, right? These are things, this particular one, as far as the coronary artery calcium score, is 1000% something that even men should be thinking about. And when should we be thinking about that? So first, let's just start by saying, what is this test? So if you can think about, the heart is the pump, and then all the vessels that lead from the pump, that's considered your cardiovascular system. Well, the heart itself has vessels in it, right? It has to feed itself. So those coronary arteries, those vessels inside the heart, is what this test is looking at. And what it's doing is, when you go for the test, they put some stickers on you, and that spits out an EKG, right? The EKG tells us the electricity through the heart. So the heart is an electrical, it's all on conduction, right? So there's a unique pattern that conduction through the heart shows, and that's the EKG. And it's telling us, okay, is the top part of the heart, called the atria, are those firing appropriately? And the time it takes for that information, that conduction, to get down to the ventricle, or the bottom part of the heart, and then the ventricle pumps or squeezes, and then blood goes out. The conduction, that system, is what spits out on an EKG. And then there's very unique parts of the EKG that tells us, okay, the atria is firing, the ventricles are firing, and then there's a reset, and then the whole pattern starts again. That pattern is your EKG. And if there's slowing of that pattern, it's taking too long to get from the atria down to the ventricle, that'll show up on your EKG. If the atria is going too quickly, that'll show up on your EKG. If the time to reset is too long, that shows up right on your EKG. So we can tell a lot from the EKG on the function of the heart based on that conduction, right? The top part of the heart beats, blood goes down, sort of tells the ventricles to beat, ventricles beat, pump, blood goes back out. So you get an EKG, and then at the same time, they're essentially taking x-rays of your heart. So an x-ray picks up calcium. If you think about, you go get an x-ray, you think, oh my God, I think I broke my foot or I broke my finger. You go to the ER, you go to urgent care, your regular doc, whatever the case may be, they get an x-ray and you can see the bones, right? So bones are calcium, they're filled with calcium. So we're looking for calcium inside the vessels of the heart. Now, those calcium deposits, that's plaque. So it's looking for one, is there plaque? Two, how much plaque? Are there any vessels that look like they may be blocked, right? So we're looking for presence of plaque. How much plaque? Is there any blockage of vessels because of that plaque burden inside the heart? That's your coronary artery calcium score. And then they give you a score. 0 is really no plaque, which then again is very low risk. There's 1 to 99, there's over 100, there's over 300. So it tells us, okay, how much plaque burden is in the heart. Now I will say, when we think about the development of plaque, it takes time for that plaque to become calcified, for calcium to sit over the plaque. Initially, when we lay down plaque, it's kind of fatty, right? It's a fatty lipid substance that is unstable because it hasn't been calcified. So over time, our body will lay down this fibrous or calcified plaque. So a coronary artery calcium score, we have to take that in context, right? Because you can have soft plaque and it will not pick up on your coronary artery calcium score. So that test will pick up hard plaque or calcified plaque. So when you get a score of 0, it may be like, sweet, I'm fine, I've got no risk, but you may have some soft plaque. So again, this requires, when we do things in medicine, we have to be sort of judicious with who are we doing this test on, and are we using it in the right setting, and then are we giving the right kind of guidance, because a score of 0 is not a free pass. You can still have some risk, so we have to take that in context. But at least for you to understand, what is the test, what does it show us, and then when we get the score, making sure that we're being prudent with how we interpret that score. So again, it's the vessels themselves in the heart. Is there plaque in them? How much plaque? Are there any blockages as a result of that plaque burden? And that's your coronary artery calcium score. So that's just, what is the test? So we say, okay, well, when do we order a coronary artery calcium score? There's a couple different scenarios. One is, so a lot of, in medicine, in medicine, a lot of what we do, at least right now, is predicated on, should we start a medication, right? When we take care of folks, everything is disease driven, right? When you are pre-diabetic, you have reached a diagnostic threshold. Okay, now you're pre-diabetic. Now we start with, this is the algorithm, right? We treat with metformin, we treat with this. Or, you are type 2 diabetic, then we've got that algorithm. You have high blood pressure, hypertension, here's the medication. There's a bunch of calculators we use to say, okay, what's the first line measure? Should we do lifestyle, right? Everything is very disease driven, because then that tells us what's the medication. That's the way healthcare runs right now. So even this coronary artery calcium score, why do we order it? Well, again, we're ordering it to decide, should we start a statin, right? This cholesterol lowering medication. Cholesterol is a fatty substance. It's lipid, right? So again, that soft plaque starts as a fatty deposit. So it's your risk for developing a plaque is dependent on your cholesterol panel, right? Your total cholesterol, your LDL, your triglycerides. All of those things increase your risk of developing that lipid accumulation or that fatty substance inside your artery that later gets calcified. You get a calcified plaque. That plaque now shows up on your coronary artery score. So we're using it to help us decide, well, should we be starting a statin on someone? There's the clear-cut case, right? Someone whose LDL is well over 190, their total cholesterol is, well over 200. Absolutely, we should be talking about starting a statin and lifestyle. So for me, lifestyle is always in the bucket. But if someone's exceptionally high risk, starting a statin. But now we kind of bring it down a little bit. Someone's in the gray area. At least when we do our calculator, there's something called an ASCVD risk assessment or calculator. When we do that calculator, they fall in kind of the low risk category, right, or intermediate risk. And that calculator tells us what is their 10-year risk for having a massive first time coronary artery event, heart attack, stroke, that kind of thing. You can't use it for someone who already has had a heart attack. So this is someone who's never had any heart attack, no heart, event. We plug some numbers in and we say, okay, what is your risk of having your first time event? In that calculator is your age, it's your sex, it's whether or not we're treating you for hypertension or high blood pressure. Do you have diabetes? I have to look at it. It's crazy. I do this thing all the time and I still always have to look up what's in there. Yeah, your total cholesterol and your HDL. And your race, and we plug that all in there, right? And we say, okay, based on that, good morning. Based on that ASCVD risk, it'll tell us, should we start a statin? If we should, what's the intensity of that statin, right? So now we're talking about people, when we put in that risk, it says they're not at the level where we would start a statin. But are they at risk now? So we think, should we use this coronary artery calcium score to define or to help us make an assessment of should this person still be on a statin, although their ASCVD risk calculator says they're kind of below that threshold. So that's one way we can use it. The other way is to say, wow, hey, you know what? I'm seeing you. I think you should be on a statin, but the person's uncomfortable with a statin, right? I don't know, doc. I hear all this stuff in the internet. There's somebody on Instagram who took a statin and they had awful leg pain. They say their mom got dementia because of statin. I'm terrified of this medication. I don't want to start a statin. Do I really need to? Okay. Totally hear all of those reservations. We can talk through all of that. Why don't we think about doing this coronary artery calcium score? Let's keep in mind, though, that this only shows calcified plaque, right? For me, I've already had the conversation about lifestyle, right? We've been doing lifestyle from day one. If you find me, it's either because you believe in lifestyle and you know that it has some validity to it, or you find me and I talk to you about lifestyle and you're like, yes, I want to do that thing. Most people don't stick around with me if they have no interest in modifying their lifestyle. So for me, I'm already talking that, right? We're already talking about, what are you eating every day? Are you sleeping? Like all the things that you hear me talk about ad nauseum, which if you're still following me, that means you kind of get that. So we've done all of that, right? We've been having that conversation. They understand the power of lifestyle, nutrition, motion, managing your stress, all of that stuff. Their scores are high, right? Their cholesterol, their LDL. You know me, I'm looking at that triglycerides to HDL ratio. I'm looking at other things, right? Their high sensitivity CRP, their fasting insulin. I'm very early in my conversation. I'm not waiting for you to get to a disease state or a diagnostic threshold. So we're doing all of that and they're in that bucket. And even with everything, I'm like, you know what? I think you're at that point where we really should be thinking about a statin. They're super hesitant. And we say, look, let's look at a coronary artery calcium score. Let's see, do you actually have calcified plaque yet? Or is the presumption still soft plaque? To help us, again, just further tweak your risk, that's one scenario where we may look at using a coronary artery calcium score. So either kind of gray area with the ASCVD, we're not quite sure, here's one other test we can look at. Or gosh, I think you should be on a statin. I would recommend you should be on a statin, but the patient is hesitant and they're just not quite comfortable. Yes, let's look at a coronary artery calcium score and see, is it of value? Those are kind of the gray areas, right? Or actually another one is, hey, I was on a statin, but I stopped it because I couldn't tolerate the side effects. I don't really want to go on it. Should I really be on it? Right? That's another one where we can say, all right, let's look at this coronary artery calcium score to see, are you really in that bucket where I would really start to think about, gosh, all right, I know we're managing side effects, but risk versus benefit, right? Everything in medicine is a risk versus benefit. So those are the buckets of when we would use it. When not to use it. Somebody who's super young, has no risk factors, and again, when I look at their labs really would not give me pause, wouldn't say, ooh, I've been trending your things, and maybe, even though you're not diagnostic, but there's some things that have been trending, or in their case, not trending, right? Really, their trends look amazing. I know they're dialed in with their lifestyle. I really have very low concern about plaque burden. I wouldn't order a coronary calcium score. It's of no value. There's no reason to spend that money or that time. It doesn't change my treatment algorithm. It doesn't change how I would manage them. So in those cases, I wouldn't order it. The other person I wouldn't order is a person who's already had a heart attack, right? We are going to optimize them to the 9. So that person, again, not indicated for a coronary artery calcium score. So it's kind of the gray area. I started a statin, didn't tolerate it. Should I really be on it? Ooh, you should be on a statin. I'm a little nervous. Do I really need it? Yeah, let's look at a coronary artery calcium score. I think the other people, again, in my case, because I order more, I really am very much kind of an early person. One of my patients said, like almost like uber preventative, super preventative. I look at that lipoprotein A, right, to say, gosh, is that an added risk factor for you? And although your total cholesterol and your LDL, again, by that ASCVD says not needed, but your lipoprotein A is high. I think a coronary calcium score, that's when we would be adding that. Lipoprotein A being high may also indicate statin, although again, that ASCVD says no. I'll tell a sidebar story because it demonstrates how amazing direct primary care is. So typical healthcare, you go see your doc, they need you to see a specialist. You put in the referral, takes months. I put a video on the other day. It takes months to get into a specialist. You pay whatever your copay is to see a specialist. It's a 15-minute visit. They send you back. So in direct primary care, I can do an e-consult. I was just amazed at how efficient this was. I put in an e-consult. I gave that cardiologist everything I needed to tell them. I went to sleep. I woke up the next morning. I had an answer that I could then coordinate with my patient to say, this is going to be our treatment. And they never left their house. They didn't have to take time off work to do that. It's amazing what we can accomplish in direct primary care. It continues to blow my mind. So I just love it. Sorry, segue, sidebar. Anyway, so lipoprotein A would also change, right? Their risk. That's a risk factor. Menopause, risk factor. And that's why, again, it's important to have somebody who is watching the store in totality, right? Menopausal female, perimenopause, we know as that hormone, estrogen and going through those hormonal changes, it increases our risk for cardiovascular disease. So again, should we be thinking about this coronary artery calcium score? Your doc is getting your total cholesterol. They're kind of saying, oh, it's a little high. You're fine. You don't need to start a statin yet. But you're perimenopause or menopausal. We know that those hormonal changes increases your cardiovascular risk. Should you be on a statin? Well, maybe looking at a coronary artery calcium score would modify that recommendation. Maybe you should. Maybe you should be being more aggressive with your lifestyle, right? I think a lot of times when I talk to patients and they're eating what's considered the standard American diet, and I'm trying to transition them onto more of a nutrient dense, whole food, plant predominant eating pattern, and I'm talking to them about reducing their alcohol, and I'm talking to them about starting to create some significant motion in their life and exercise and strength training, and they're a bit resistant, and we've got a coronary calcium score that's high, that may kind of motivate them, right? They don't want to start a statin, but that may motivate them to run up that hill a little bit faster, right? So it changes things, and knowing what a person's risk is important. So, taking care of women throughout our lifespan, we have to be treated in a way that is consistent with our risk, and understanding that perimenopause and menopausal transition rapidly increases our risk for cardiovascular disease. And we need to have this test at the top of our mind to say, is this the person that I should be getting a coronary calcium score on? Is that going to change my recommendation? Is it going to change their ability to manage their health a little bit better? Is it going to change whether or not I start a medication a little bit sooner? So adding that. So menopause is a risk, right? We got to think about that. So hopefully that helps. So now we get the test back. What does a test mean? So again, you get a score of 0. This is all predicated on whether or not we should start a statin. So a score of 0 says, okay, low risk, no indication for statin. Caveat, please, caveat. A 0 means there's no hard calcified plaque. It does not tell you if you have soft plaque. Soft plaque is still a risk. That is looking at your labs. That's knowing your lifestyle. That is knowing, are you menopausal with an increased risk? That is, do you have an elevated lipoprotein A? That is, do you have high fasting insulin, although your hemoglobin A1C is not diagnostic? Is your uric acid elevated, right? Triglyceride to HDL ratio. All of these things will tell me, do you have risk for soft plaque, although your coronary artery calcium score is 0. So please take it in context. But again, straight medicine, straight insurance-based healthcare, a score of 0, if your doc is not dialed in, will tell you you're good. You got no hard plaque, your score is 0, you're low risk, no need for statin, because that's the guideline, right? Then you've got a score from 0 to 99, increased risk, consider a statin. Think about it. Because now you've got some calcified plaque, you should consider starting a statin. Again, that's the recommendation that we are going to get as a doc. Doc will then pass on to the patient, we should consider a statin. Then over 100, absolutely, you're in statin territory now, right? Over 300, that is like step on the gas when it comes to reduction of risk. That is step on the gas, get in to see a cardiologist, interventional cardiologist. Should you get a coronary, should you be getting a cath? Like that is like, holy moly, right? A coronary calcium score greater than 300 is really maximum management. By God, I hope you've got a doc that has been talking to you because again, the tea leaves have been there, right? We don't get a coronary artery calcium score over 300 overnight. That does not happen overnight. You've been brewing for years. And if your doc has been managing the store and they've allowed you to brew for years and you've got a coronary artery calcium score over 300, good Lord, it doesn't happen overnight. Again, read the tea leaves, trend labs, right? Watch what that stuff has been doing. Listen to your patient. Make sure you're living that lifestyle to minimize that risk. Are you menopausal? All of these things, right? So, but the score, 0, you're good. Don't need a statin in traditional healthcare. And if that's what your doc is looking at for statin recommendation, they're going to say no statin needed. 1 to 99, consider. Over 100, you need a statin. Over 300, step on the gas. That's maximum risk reduction. No bueno. You do not ever want a score of over 300. So that's coronary calcium. So now let's just do a couple things. I think the case studies worked well a couple weeks ago when I did them. So I wanted to think about, okay, how do I actually apply this in real life? So I'm going to read a little bit, so I apologize. So let's say I'm taking care of a woman, 50 years old, right? So kind of, menopausal. So that's a risk, right? I'm already thinking, okay, she's at risk. Her total cholesterol is 220. So that's over, right? So we want a total cholesterol under 200. Again, conventional statin therapy, under 200 is the goal. She has no diabetes, conventional medicine. So her A1C is negative, and I'll try to stay conventional medicine because I don't want to muddy the waters. But so 50-year-old female, menopausal, total cholesterol is 220. She has no diabetes. Her LDL is 140. She has no high blood pressure, and she's not a smoker. So the question is, does she really need a statin, right? So by this convention, statin therapy, it's a no-brainer if your LDL is over 190. So at 140, her total cholesterol is elevated. Her LDL is elevated at 140. She has no high blood pressure. She has no diabetes. She's menopausal. That's a risk factor. Does she need a statin? So for me, we're already doing lifestyle. She's trying. She's making some motion. But should we add a statin? So we could consider doing a coronary artery calcium score, right? Because menopause is a risk. So in her case, we can get a coronary artery calcium score to say, okay, would that push me over the edge to say, gosh, should we be giving you a statin? Although an LDL of 140 doesn't say you need a statin. She's kind of in that gray area, but then menopause is a risk factor. So we can add that as another piece of information for the patient, as well as for me to say, should we really be thinking about a statin? So then we can get a coronary artery calcium score. Now, if her score is 0, right, then we can say, okay, you don't have any hard plaque. So that's a good thing. You don't have hard plaque. But again, that lipid profile and menopause tells me that you're at risk, likely for some soft plaque. So then I would still say, okay, awesome, we have a score of 0. Maybe we don't start a statin, but we continue to be aggressive with lifestyle. And I would encourage that aggressive lifestyle management. Now, let's say she's got a score over 100. Then I would change, right? Then I would say, gosh, maybe we should think about starting a statin and still continue to do lifestyle. So there it would change my recommendation whether or not we should start a statin. If she has hard plaque, then the recommendation likely is to start a statin and continue to do lifestyle. So in that case, getting a coronary artery calcium score would be helpful because it would change the recommendation. If she had a high lipoprotein A, right, then it would be start a statin. Maybe the dose would be different if also her coronary artery calcium score was higher. Again, over 100. So now we've got a statin. Maybe I started a low dose statin, but then the coronary artery calcium score was high, over 100. Maybe we increased the intensity. Maybe her treatment, what am I treating to would change as far as the LDL number. So all of that would inform and would modify my treatment. So then there's value in getting that test, doing the coronary artery calcium score. There'd be some value in that. So now we've got another scenario. I've got a 55-year-old, fit, super active, right? Total cholesterol's 210. LDL's 125. So that's pretty low, right? It's not, I would love if everybody's LDL was under 100 without no family history of early heart disease. Under 100 would be great. So pretty darn close. Total cholesterol's 210. She's menopausal. Some of that could just be menopause. Triglycerides are a little bit elevated. It's basically X-ray. It's CT, right? So it's X-rays of your heart. They do an EKG at the same time, and then it's a series of X-rays to see if we're picking up calcium inside the coronary vessels. So that's what the coronary artery calcium score is. So for her lipid profile is not bad, but she has family history of heart disease, right? Family history of heart disease, so that's a risk. And her lipoprotein A is not elevated. So in her case, family history, I would say, hey, we could certainly consider that. We could consider it. Now, she had no family history, but she's menopausal. So then that's conversation, right? Then we say, okay, what is this going to add? Would they really start a statin, right? If let's say we got a coronary artery calcium score and it was 50, that's still middle of the road. Would that person really want to be on a statin? And that's a conversation. If it's not going to change, then we don't get the test. But if my patient says to me, no, if I saw that I had hard plaque already, I would take a statin, then yeah, let's think about that. So it's about having a conversation and evaluating risk to say, should we be adding this additional piece of information? Is it going to change our treatment? But if she's super healthy, cholesterol panel's a little bit elevated, could that be menopause? Has some family history, lipoprotein A is not elevated, I would say let's consider that. No family history, middle of the road, we talk about, is it going to change our treatment? Now, let's say we've got, somebody who is 45, for whatever crazy reason, they've already had a heart attack. No, there's no value in getting a coronary artery calcium score on that person. None whatsoever, male or female, because they've already had an event, right? We are on like maximum medical management. Or a 65-year-old who's had a heart attack. No, we are on maximum medical management. Medical management for me is aggressive lifestyle. Your sleep is dialed in, all the things, medication as needed. We're reducing your insulin resistance, your inflammatory burden, all of the things that I talk about. We are like full court press on that one. Yeah, so there's no value in doing the coronary artery calcium score on that person. Those were the two scenarios. What questions? Any other questions from me? Oh, coverage. Is this stuff covered? Sometimes not. Insurance, right? They're not necessarily in the business of healthcare. In fact, they are not in the business of healthcare. Insurance has no interest in healthcare. Insurance is a money game. It is managing risk. It's who do we spend money on to manage our long-term risk of having to pay things out. So that's all that insurance is there for, is to spend as little as possible and collect as much as we can. So sometimes it's covered, sometimes it's not. I will tell you, you can get one for cash in a lot of cases, anywhere from $100, sometimes up to $400, but 100 to 150, less than $200, you can get a coronary artery calcium test done, score done. So even if insurance doesn't cover it, and I get it, right? Not everybody's in that position. I am not here to say that some people have $100 to $200 lying around that they can get this test done. So I totally get that. But yeah, it's not always covered by insurance. So we play the game, right? As a doc, you try to stack the deck. You do what you can to support your patients to get things covered, but insurance is the one who makes the decision on whether they're going to cover things or not cover things. But if we really think it's necessary, if there's a way to pay cash, there's definitely ways to get it done for cash, assuming patients are able to do so. Yeah. What questions? Anything? And again, this is, the Thursday series are about menopause, but this one is definitely not just applicable to women. This is also applicable to men. So please share this with, talk about this test, share it, make sure that the men in your life understand the value, when it should be used, when it shouldn't be used. Is their primary doc talking to them about this? I think I've gotten a few men who've been interested, for me to be their primary care doc, and they're like, do you take care of men? Yes, I do. Yes, I do. I talk a lot about women's care because, we've been forgotten in medicine, but I absolutely take care of dudes too. So happy to have them in my practice. So talk to the men in your life, make sure that they're being cared for and that somebody is watching the store and talking to them about these other things, right? In addition to lifestyle, reading the tea leaves, who's trending your labs, who's talking to you about, are you headed in a direction? Let's talk about prevention, not just waiting for people to reach this diagnostic threshold that insurance will say, oh, now we start medication. God, don't do that, right? Talk about it before they get there. Help people not ever get there if we can. So, yeah. And again, if you have questions, send them to me. They become these lives. So somebody else has the same question. So send me the questions so that I can answer for everybody. All right. There's nothing else. Thank you, as always. I'll share the video. Have a fantastic rest of your week. Enjoy your weekend. Running a 5K this weekend, which should be fun. I'm excited. I love races. I'm going to take it easy, though. Yeah. But, yeah. All right, let's see. No hypertension. No diabetes. I stopped eating out in March. Oh, yes. Heck yeah. Boom. High five. Solid work. Good for you. Oh, congratulations. Sorry I haven't seen you. I haven't been down that way in forever. I don't get down there very much anymore. But, oh, congratulations. That is amazing. Kudos. Good work. Good work. Was it hard? Like, do you feel... Because I always like to ask people when they start to make lifestyle changes, I don't want people to also feel super restrictive. I thank you. Where they're like, they can't live like this. Like, the goal hopefully is for people to make this their lifestyle. Just, this is who they are, right? They are a person that chooses to prioritize their nutrition and chooses to do all these things. Not, I'm on this diet and I'm so miserable and I can't have X, right? So how is this transition, this lifestyle change, how's that been for you? Yeah, love it. Love it, love it, love it. High five. Woohoo! Congrats. Keep it up. I love it, man. Stacking the deck in your favor, because what we do now, that's what dictates like your 60s and your 70s, if you put in the effort. I hear you. Okay, I hear you. Well, good luck with that. Keep it up. Congrats. All right, have a fantastic day, everybody. Enjoy your weekends. We'll see you guys next week. Take care. Bye-bye.